6, 3. Good morning. This is Dr. John Bennett broadcasting from beautiful Miami Beach. We have the pleasure of broadcasting the semi-monthly, the bi-monthly China Neurosurgical Neurosurgical Journal. And today we have, we have Li Kao, and we're going to let Bin Zhu, the famed neurosurgeon, that just got back from Boston. We broadcasted him in Boston. Good day, Ben.
Okay, thank you. Thank you, dear audience. And now let's welcome Professor Li from Tianshan Hospital, presented his experience. Professor Li,
okay.
Now, please.
Thanks for the introduction. So I share my screen. Okay. So can you see my screen? Okay. Can you see my screen?
Yes. Not okay. Put presentation mode. Yeah. Perfect.
Thanks. Good morning, good afternoon, and good evening, everyone. So thanks for the invitation, and it's my honor to be here to give a talk about the endoscopic and nasal resection of the third ventricular craniopharyngiomas in adults. So first, let me introduce myself. My name is Li Cao, and I come from the Beijing Tianshan Hospital. And now I'm visiting the UCL and the King's College Hospital in London. And today, my topic is about the feasibility of the endoscopic and nasal resection of the third ventricular craniopharyngiomas in adults. So as we know, the intrinsic third ventricular craniopharyngiomas are the tumors are deep-seated in the third ventricle. So it was surrounded by many vital nerves and vessels, especially the hypothalamus. So it was reported that the IVCs is to be the one of the greatest surgical challenge to our neurosurgeons. Until now, a variety of the surgical approaches have been introduced to be used for the resection of these tumors. So from the anterior to the posterior, we can see that we are using the subfrontal, subtemporal, and the anterior transcortical or anterior transcallosal, and so on. All these approaches can get access to the tumor located in the third ventricle. So in 2008, Kassam in the UPMC, we reported a classification of the craniopharyngiomas. So they based on the relationship between the tumor with the stalks. So in the first three types, there are the pre-infundibular, transinfundibular, and the retroinfundibular. But they specified that there is a type 4, which is isolated to the third ventricle or the optic recess. And this type 4 tumor was not accessible via the endoscopic and the nasal approach. So it seems to be a surgical exclusion for the IVCs to be resected by transnasal approach. But with the development of the equipment of the endoscopy and the technique, so now whether the IVCs could be resected successfully or safely, we use using the transnasal approach. So we do explorations in the last few years, and this from the 2018 to 2020, there are almost 200 cases of cranials was involved in my work by the Professor Zhang and Professor Gui. So in this series, we got 22 cases, almost 11%. They are the IVCs. And this is the gender distribution and the age distribution. We use the 5 MRI criteria for diagnosis. So we use the hypothesis an intact or normal size pituitary stalk descending from the gland is viable, and the thoracic is free of tumor, and the asthmatic system is viable. And the most important two characteristics is the MBA. This is the angle. So we use the 2 lines. The first line is through the mammary body, and the second line is parallel to the floor of the fourth ventricle. So they form the angle. So normally in the human, this angle is equal to 60 degrees. So when there's a tumor located in the arised from the third ventricle, so they can push the floor, the third ventricular floor downward, so make this angle lower than 60 degrees, and the floor was placed at or below the lower 1/3 portion of the tumor on the coronal MRI. So according to the integrity of the floor, so we subtyped it into 2 subtypes. One is the intact floor IVCs, and the other is the lacerate floor IVCs. And these 22 patients, all the patients received an extended endoscopic transnasal approach. We use the forehand technique. And in the operative, we use the intraoperative, the VEP monitoring to monitor the infection, the activity of the virtual pathway. And for the skull-based reconstruction, we use the nasal septomuscular flap or the fissure. This is the result of our this series. So the tumor resection is we achieved almost 95% of them, and only 1 was near total resection, because this tumor, we found that some part of the tumor is attached to very tightly with the vessels, so we leave that part. And this is the pathologic result, and we can see the almost the half of the ACP and the PCP. But when we found in the 2 different groups, we can see in the lacerate TVF IVC is more common in ACPs, and for the intact floor tumors, they are the PCPs, are more common in PCPs. This is the visual outcomes, and most of them, the visual outcomes is improved or no change, and only 2 cases have a deteriorated visual outcomes, and but some of them suffered from new pituitarism and the new diabetes insipidus. The post-operative complication is one case have a CS leak and required endoscopic repairment of this leak, and no patient died in this series. And 1 patient recurrent and received following gamma knife radiotherapy. Okay. So for the surgical findings, and first I will talk about the surgical findings and the MRI correlations. So this is the IVC, and sometimes we have to differentiate from the tumor which arises from the supercellular region. So they also can press the floor upward and occupy the third ventricle. So sometimes it's difficult to identify which type. So I've talked it in detail in the following slides. So the first one is the floor is intact. So as I talked in before, so I made the MBA, so this angle is lower than 60 degrees because the tumor proceeded down, and the bottom, the floor is located at the bottom of the tumor, and it was found intact in the surgery intraoperatively. This is one case. We can see this floor. This floor is at the bottom, and the angle is lower than 6 degrees. And we can see this intraoperative view of the third floor, and we can see it's intact. And this is the stalk. This is the pituitary, and this is the chiasm. So this is a case of intact TVF IVC. Sorry. What happened? Sorry. Okay, this is another case. So this is the mammary body. So it's at the bottom of the tumor, and it pushed down. And here is the intraoperative view, and this is the third floor. It was intact, and here we make an incision and get access to the third ventricle, and to debarking the tumor in the third ventricle. So after the debarking of the tumor, we can see this is the mammary body, and here's the tumor. So the relationship is the mammary body is on the bottom of the tumor, and this is when the tumor was removed. This is third ventricle. And the second, this is the last. If the tumor keep growing, and it can break through. Sometimes it can break through the floor and extend it into the subcellular system. So for this part, so for this kind subtype, the TVF sometimes is lower at the lower 1/3 part of the tumor. So the relationship between the tumor and the floor, so it's on the top or on the bottom, it's kind of helpful to for you to identify which is the tumor origin spot. So here is an interesting case about the lacerate floor IVCs. So this patient, when he was only 4 years old, he observed a tumor located in the third ventricle, and the floor is here and intact, but the patient didn't receive any received a surgery, but just observation. And for 6 years later, we can see the tumor grows bigger and breaks through the floor to the subcellular region. And 2 years later, I can see we can see this tumor grows bigger, and it can extend it to the chronic system. So this is the intraoperative the view. We can see that the brainstem, the brain tissue is located on the bottom of the tumor. So let me see to watch a video of the intraoperative of the operation. Okay, this is the intraoperative. We detected the arachnoid membrane to explore the subcellular region, and here we can see this is the tumor, and this is the pituitary. This is the stalk. This is stalk. So first, we debarking the tumor in the subcellular region piece by piece. And this step can give you enough space to find the plate between the tumor and the brain. So this is a tumor. So sometimes sometimes the tumor attached to the vessels very, very tightly. So we use the scissors to dissect it sharply. Okay, this is the debarking of the tumor piece by piece. And now we can see this is the brain, normal brain, and this is the tumor. So the brain is at the bottom of the tumor. So this tumor is IVC. With the tumor, sometimes we can see the tumor was attached to the brain tightly. So this is after the tumor was removed, we can see this is the moral and the aqueduct, the CS, the pathways was rebuilt. Okay, for the intact, so sometimes we need to differentiate these tumors with the subcellular craniophangiomas. When they arrive in this part, when they grow bigger, they can push the floor upward. So it also can be when the floor. So because it pushes the floor upward, so it makes this angle greater than 6 degrees, and the floor is on the top of the tumor. So this is a case of the cellular craniophangiomas. Okay, after we dissected the arachnoid membranes, we exposed the tumor, and here this is a stalk, and we must to protect these branches very well because these branches supply the blood to the chiasm and the optic nerve. Okay, here we can see the tumor is here. So luckily here we don't have so many branches, so they give some space to get access to this part of the tumor. Okay, so you can see for this part of the tumor, there's no brain was on the surface of the tumor. The first step will also is to remove the piece by piece, this debarking to gain the space. Then you can easily find the plate, and you can use the dissectors to get to the space to dissect it. So when you find the space, you will feel confident to protect the surrounding tissues and the structures. Okay. So you can see this is the floor. You can see floor here. Okay, it's on the top. So after the tumor was totally resected, so we can explore the third ventricle. This is the wall, and this is moral. This is another case. You can see. Previously the floor is here, and it was pushed upward, and to occupy the intersert ventricle. So this is operative view. We can see this is the tumor. This is stalk. So this type, this tumor is belongs to the supercellular cranial. This is another case. So this case is interesting. So we can see the floor is here, and it seems like to push this tumor is already in pre-infundibular subtype, this type 1, and you can see it pushed this recess backwards. So this is the pituitary stalk, and this is chiasm, and this is the space between the chiasm and the stalk. So the floor is intact. But sometimes when the tumor grows bigger and bigger, they can lacerate the floor and extend it into the third floor, extended in the third floor. So for this one, this patient, we can see the tumor is almost occupied all the supercellular and the third ventricle. So let me watch the video. Okay, the first step is also to dissect the membrane to expose the supercellular region, and here we can see this is a tumor. So we make it so there's no brain tissue we can see on the top of on the surface. So we open this tumor and the departing. Here you can see there's like the capsule of the tumor. So for this part, the tumor is attached to the vessels very tightly. So we use the scissors to dissect it sharply. So and then we can protect these vessels very well. When you see the boundary, so you feel confident to remove this part, of the tumor. So inferior part was dissected, was removed. So we've got a lot of space to remove the superior part. So our experience about sometimes the tumor was not attached to the floor very well, attached tightly. The plate is visible. So we use this plate to dissect the tumor. So when the tumor attached to the brain very tightly, we use scissors to dissect it. So this is better to preserve the hypothalamus function. So now this is the model, and here you can see the aqueduct. The second topic is I want to talk about is the surgical corridor. So to get access to the third ventricle by transnasal approach, there are two corridors we can use. So here we can see that this is a chiasm. So we can use a line between the pact of the nasal and the chiasm. We can make a line, and we can see we can use these two parts, inferior chiasm corridors or super chiasm corridors. So sometimes we use the two lines. The first line is from the nasal and the chiasm line, and the second is the vertical line through the chiasm. So it can be divided this zone in 4 zones. So if the tumor in 4 zones, and if the tumor was located in the fourth in zone 4, this part of tumor sometimes is like they are sitting on the chiasm. So if you want depressor after depressor, debarking of the tumor inferior, this part of tumor can't come down to the surgical field. So we must use the chiasm approach to remove this part. So when we use the inferior chiasm corridors, so we use the space we use is the chiasm between the chiasm and the pituitary space, and we need to open the third ventricle floor. Sometimes we use the midline approach, because the hypothalamus nucleus was located bilaterally. So the midline is most safe approach to get access to the third ventricle. And the second way is use the weakest point to get access to the third ventricle. So here is the case about we use the inferior chiasm corridors. So we use these two lines. You can see the tumor was located in almost in the zone 2 and zone 3. So almost half, but a little bit more in the zone 2. So we use we want to use the inferior chiasm corridor. So let's watch the video. Okay, now we can see this is a tumor, and this is stalk. This is stalk. After dissection, we make an incision along the midline to get access to the third ventricle. First, what we should do is debarking the tumor piece by piece to get to decompression, to get the plate. So this step we must do patiently. Okay. When we get enough space, so we can then it's easy for us. It's easy for us to find the space, the plate. Then we check the ventricle and to find there are still some tumor on the top. This is the final. Okay, to remove this part of tumor. This is the final view of the third ventricle. And for this case, you can see this tumor also there are some brains. So we use the weakest point access. The weakest the way we use the weakest point to get access. We make incision here and the debulking and to remove the tumor into third ventricle. So sometimes we use the suprachiasm corridor, and we use the space between the chiasm and the front lobe. We open the laminar terminus. For this, the corridor we should protect the ACA complex. So this is a case we can see for these two lines. So the tumor was located in the almost in the super line of this line, superior to this line. So we use the in the super chiasm approach with the translaminar terminus approach. Let me see. Watch the video. So at first we explore the inferior chiasm, like the CPC, the chiasm pituitary space, and we found there was we can't see any tumor here. So we decided to use the super chiasm approach. And then we explore the laminar terminus and make an incision on the laminar terminus to now we can see this is a tumor. Of course, the space is limited, so we debulking patiently. And then we can find the plate. Okay, we can find the plate. Okay, so for this patient, we just use the translaminar terminus approach to remove this tumor. So this tumor was totally removed. So we can see this is moral, this is the choroid, and we can see these are the aqueduct. This is the aqueduct. This is another case. We use the super chiasm. So you can see this is a chiasm. This is the laminar terminus. So the laminar terminus is very, very thin, and we can see the tumor here. So use the translaminar approach to remove this part of tumor. Sometimes we need to use the combined super and infra chiasm corridors. So you see for this patient, along this line is almost equally in the bilaterally of this line. And also there we can see some tumor is on the zone 4, so it sits on the chiasm. So let me see what we do. So first, we also to explore the infra chiasm approach. So we remove this part of tumor as much as possible. Okay, this is the chiasm. So when we can't do it, and then we can do it anymore, so we move to the supercellular, super chiasm. So we use the translaminar terminus. Okay, we remove this part. So you see, when you remove this part of the tumor, so sometimes these tumors can come down to the infra chiasm. So then you can see some tumors come down, and we use the infra chiasm corridor. Okay. Actually, this is attached to the pituitary stalk. To copulate it. And this is the third ventricle. The tumor is totally removed. This is the aqueduct. Okay, the third topic is about the other approaches, is the transcranial approaches. So as I mentioned before, we use the subfrontal, the subtemporal, and the transcordic, transcallosal approach. We also can use to get access to the third ventricle. So for the subfrontal or the territory, so this position, incision, and this craniotomy. But you can see when we get to the cellular region, we can see the tumor is below the optic nerve or chiasm, and we use the laminar terminus to remove this part. Sometimes we will use combined, use the first, the second, and the third space. So for this approach, you see the optic nerve and the ICA is on the top. So you need to use the space between this whiter nerve and the vessel. So a lot of blinds when you do the surgery. So this is the case I don't want to show the video of it. So we use the third translaminar approach. For the transcloser, this is better. So this is like from the top to get access to the tumor. So we make incision on the closer and use the interferometer to get access to the tumor in the third ventricle. So because we should to make incision on the closer, so the patient may suffer from the cognitive declines, and the the view is very limited. It's very limited. And the walking distance is very long. So this paper is have concluded the advantages and the disadvantages between the transnasal and the transcranial approaches. So briefly, so for the intranasal approach, so we have the excellent visualization and the later detection of the optic chiasm. But for the other, for the transcranial approach, they maybe say so the walking distance is long, and maybe we have the cognitive issues. Here's the surgical complications. So compared of the with the other series. So our this series is the largest series, and you can see the result of the surgery. The tumor can be resection can be almost totally removed, and the complications are acceptable. So the EEA also offers a direct midline path to the radiochromatic space, and to give the excellent direct visualization of the entire surgical field, and it is feasible for the intrasert ventricle to remove the intrasert ventricle cranial. And I think we should consider this approach as a first line approach if you are mastered this technique. So that's my talk. Thanks for your attention.
Thank you, Professor Cao Lei, and thank you for your very informative presentation. And do you have any experience if some perforators from ACA to the craniopharyngioma, if it's attached very hard?
Yeah.
How do you treat these perforators?
So sometimes the patients with the tumors, the SA is very like anteriorly, and sometimes we use the sharp dissection and to find the plate between the artery and the chiasm, and then we use the patty to push this anterior part, the ACA, to backward. And when after you debarking the tumor, so the pressure is calmed down, and sometimes we have enough space between the artery and the chiasm. So that's our experience. So sometimes we first we try our best to use the inferior chiasm space to remove the tumor. So if the pressure is calmed down, so sometimes there are a lot of space for you to separate this separate the ACA from the chiasm.
Okay, thank you. So if it's because I noticed in your presentation and some of the tumor are quite large, so do you use sometimes combined approach like transvenous approach combined endovascular endoscopic combined with some choriotomy approach?
Thanks for your question. So actually for this series, this 22 cases, all of these tumors were removed by a transnasal approach. So you know, if you want to use the cranial, sometimes you are worried about the tumor, the superior part. So we use we can in the endoscopy we can use the laminar terminus. So it's the same for you to do the transcranial approach. So for this part, we just use I think the endoscopic and the nasal approach is enough. It's enough for them.
Okay, thank you, Professor Cao Lei. Can you read the questions from Hashad? Professor Hashad is he has a question: what criteria you decide which approach you select, EEA or terminal approach?
So for the here, so for the cranial, you know, for the tumor located in the third ventricle, so it's almost in the midline. So for the midline, so we always use we prefer the EEA. We don't prefer the terminal. So, but if the tumor is like the located in the supercellular, so sometimes it can extend it laterally. So when it's extended laterally of the artery, so we can't get access to that part by the sphenoid approach. So we just maybe will leave this part and do a terminal approach or subfrontal approach like this, the transcranial approach to remove that part. So if the tumor is located laterally, true lateral, so we can't use the endoscopic approach.
Okay, thank you.
Okay, thanks.
Very good.
John.
Yeah, I don't know if you have any, Martin, do you have any comments or questions on Dr. Cao's excellent presentation?
No, it was an excellent presentation, and I really believe that endoscopic is the way to go. The one thing I note, obviously, these are all fresh tumors. You can do recurrent tumors as well in the same technique. You're in the right plane, you're in the right angle. You know, the dissection, what I always find when I do some endoscopic stuff is we tend to do a lot of pulling. And obviously you can get away with it, but in other areas like Vinshu was, you know, saying you don't want to pull on perforators, for example, but there aren't any, so you can get away with it. And this identification of the plane, there is always a plane around these craniopharyngiomas. Is a little bit hindered by the fluids and the blood. So yes, I guess if you just do it carefully, you can just pull everything down and eventually. And I see you using this periosteal type of sharp dissector, or a dissector which doesn't have a blunt edge but has a sharp edge anyway.
Yeah.
So probably that is very useful. I don't know. Are there any other? I don't. The scissors might get you into trouble if you use them too much. So probably that dissector is. Are there any other instruments you like to use?
Thanks for your question. So sometimes we like to we use the scissors, like the carved scissors or straight scissors.
Yeah.
And sometimes we prefer the like the plate dissector. So the plate dissector is like it's not so blunt, it's not so sharp. So you also it's better for you to find the plate, especially on the surface of the tumor. Yeah.
So I don't know. I mean, Professor Yasuke, a long time ago, he obviously was a big fan of perioneal. There was no endoscopic approach, and yeah, the results were sometimes mixed. And this, I don't think you see so much hypothalamic problems with this approach. I don't know. Can you comment on that? You said in 21 cases you practically had no morbidity, right? Except that the pre-existing endocrine status was not improving, which is okay. You know, I mean, yeah. So I think endoscopic, for people who don't do it. So if it is available somewhere in your country, it is a good idea to either go and learn it. It's not that difficult, or else refer the case, the perional approach, yes, if it's very lateral and encasing
Yeah.
even the big arteries and going
Yeah.
to all the dangerous perforating areas, the the ICA bifurcation. Sure, I mean, these cases need to be treated with craniotomies, yes.
Yeah.
Oh, thank you, and excellent. I will, next time I'm in China, I will come and see you doing this case like this, okay?
Thanks for your comment.
Okay, okay, thank you.
Thank you, Martin. And John,
Yes, any more
How about,
comments or question?
about
Harsha, I
the-
think has another comment.
okay,
Yeah,
okay.
yeah. Hi, Professor. Great talk. And yes, craniopharyngioma remains a really challenging case to remove the tumors, totally or subtotally. And we all face from time to time about the recurrences and all these things. Regarding approaches, I'm a great fan of Yasgil, and so I'm a great believer that it works through perional. But this endoscopically also, yes, one can do it. Is there any difference of approaches if the calcification is seen in the tumor and the calcification is more in the cellar area rather than a supracellar area? Do you find this it is better to do a endoscopic or a transcranial? Second thing, any difference you have observed if you have used the exoscope? Is there any role of exoscope or anything better by exoscope doing this craniopharyngiomas? Third thing, any difference in the visual deterioration, transcranial versus endoscopic? What is your experience in this?
Sorry, what's the first the question?
First question was, if there is a calcification within the tumor, if you see a chunky calcification, what we call a large calcified, and it is seen in the more of a cellar area rather than supracellar, does this differ the approach, or you still do endoscopic approach? That is the first question I'm asking.
Okay, so we always use we prefer you use the endoscopic approach to remove the tumor and by transnasal approach. So because I think it's easy for it's the visualize of the tumor, the plate, the tumor, and the relationship between the tumor and the surrounding the vessels. So you can use the endoscopy to visualize directly. So you can protect this part carefully. But sometimes if you do the transcranial approach, so there's a lot of we can say the blind. So sometimes we use to push the tumor to the surgical to the space when you do the surgery. Okay. So we prefer the EEA.
Well, Professor
Any
Charlie,
difference?
Professor Harshad's question is about the calcification. If it's there's some big part calcification, how can
calcification?
what kind of
sorry, sorry.
Yes.
Okay. Yeah, so it's challenging. So sometimes the calcification, most of the tumor, the calcification was not so solid, and like entire part of the so it can be removed piece by piece. But we also have some experiments. So the calcification is very like a stalk, like a stove. So we use the I don't know what the tooth was like a cutter. It's not cutter, like to remove this part piece by piece and Yeah, it's very hard. It's very hard to remove. So sometimes we use the drill. We use the drill to remove. Sometimes we use like cursor to remove, to make it smaller and smaller. And sometimes we separate into small pieces, and we can grasp this calcification out of grasp them. So, but I think this classification part is very it's challenging. It's very big. Yeah.
Okay. Any more comments or questions from the panel? Okay, great. You know, Dr. Sufinov unfortunately had emergency neurosurgery and cannot make it today. He didn't have time to notify me. I'm sure all you guys have been there where you just don't have time. You have to go right to the OR. So, and thanks, Ben, for coming in on the way back from Boston. Maybe we can get a little report from you how things went. I mean, there you are in Boston. It's such an old building. That's compared to China, it's not old, but the United States, Harvard's at a place where it's the oldest part of oldest education. Harvard has been there for 200 years, which is a long time for this country. Excellent webinar. We had the top, including Ben, Michael Lawton, Louis,
Yes.
etc. Did you enjoy it, Ben?
Yes.
Yeah,
Professor Al-Mufti was there.
Yes.
Al-Mufti
He was chairing the
host.
session. Excellent session. Yeah.
Mhm.
Our James Liu spoke on some acoustic neuronomas and many. Wonderful meeting it was. And the questions which were put in and the cases were superb. And yes, something good to learn from the Boston meeting also. Wonderful.
Yeah, and the good thing
Well
was
done.
to me to televise it. That was very nice
Yes.
to do that. So
Yes, wonderful.
Yeah, John, thank you very much.
Dr.
Thank you.
Sufinov is going to speak in 2 weeks, so he's going to reschedule. So thank you everyone for coming.
Okay.
Thank
Thank
you.
you, Professor.